So, hello friends, let's start with the next part of our discussion, that is chronic gastritis or that is peptic ulcer. We'll discuss all of this. Okay. Now, first we will focus on the etiology. What are the basic etiology for the chronic gastritis or your peptic ulcer? So the etiology is almost same for both of these. So starting with the etiology. So first the drugs, NSAID. Okay, sorry. The first will be your drug NSAID, because NSAID causes reduction in prostaglandins. You are knowing that prostaglandin is protective in nature for your mucosa. Then if any case of burn or if the patient is in shock, that will cause hypovolemia, that will leading to ischemia. So there will be less blood supply to the mucus, and blood is also a protective factor for the mucosa. In case of uremic patient or H. pylori patient, H. pylori releases urease, which lead to release of ammonium ions, and that will inhibit your gastric bicarbonate transporter. And you are also knowing that gastric bicarbonate basically is a protective factor for the mucus. So these are the main factors. Other factors may be bile reflux or viral infection, CMV. Okay, CMV infection will be there, or there may be bile reflux or alcohol. These are other factors which may lead to gastritis. Now, so we have discussed about the etiological agent and what are the effect of this etiological agent by decreasing the prostaglandins or getting ischemia or inhibiting gastric acid or gastric bicarbonate transporters, or it also interfere with your epithelial regeneration power. Okay, epithelial regeneration power is also impaired due to these effects. So this will lead to your gastritis, and basically these types these etiological agents are basically responsible for acute gastritis. Getting your point? Now coming to the chronic gastritis. So there are two types of chronic gastritis, type B and type A. Before going for the chronic gastritis, let's discuss about the mucosal diseases which are related to stress. Okay, before going to chronic gastritis, I want to discuss the mucosal diseases which are related to stress. Just I will give a brief intro about that. So it is a various type. The first one is your stress ulcer. Okay, the second one is your curling ulcer, and the third one is your Cushing ulcer. So there are the three types: stress ulcer, curling ulcer, and Cushing ulcer. This stress ulcer are seen with the patient of shock or patient who are suffering from sepsis, okay, or severe trauma. The curling ulcer, they develop in the proximal duodenum basically, and this is seen with the patient who are suffering with severe burn or trauma. And this Cushing ulcer, this is seen mainly in stomach, duodenum, or esophagus, anywhere, and it is seen in patients who are suffering from any intracranial diseases. So these are important MCQ question. Okay, these are intracranial diseases, and the basic etiology behind the mucosal disease which are related to stress is ischemia. So ischemia is the basic etiology behind stress induced ulcer. So behind stress induced ulcer, ischemia is the main etiology. Clear? Okay, let's move to the chronic gastritis. So two types, type B H. pylori associated, type A your autoimmune. Now coming to the H. pylori gastritis. So first we will discuss about the some virulency of the H. pylori or the mechanism of action of the H. pylori which is leading to gastritis. So first point is flagella, and they help in attachment to epithelial cells. Then your urease enzyme, that will increase amount of ammonia, that will increase pH and help the bacteria to survive. Then two KAGE, VAGE, they are very important. They are responsible for recruiting inflammatory cells, and they are also responsible for disease progression. You have read in your microbiology topic about H. pylori these points: flagella, urease, or KAGE, VAGE. Okay, and this H. pylori gastritis basically also known as antral disease, because H. pylori first attack the antrum. Okay, Helicobacter gastritis is predominantly localized, and mostly it affect the antrum, causing antral gastritis. So it is also important, antral gastritis. H. pylori gastritis means antral gastritis. Okay, now in biopsy you will get intraepithelial neutrophil. This is very important. Intraepithelial neutrophil plus subepithelial plasma cell you will get. This is very important point. That is biopsy. In biopsy you will find intraepithelial neutrophils and subepithelial plasma cells, plus there will be lymphocyte also. So remember these 3 points: intraepithelial, neutrophil, subepithelial, plasma cells, and lymphocytes. Clear? Now, coming to the demonstration of H. pylori. How will you demonstrate H. pylori, or how will you diagnose the patient of H. pylori? So it is done with Giemsa staining. Okay, we can demonstrate H. pylori by doing Giemsa staining, or we can also do Warthin silver staining, that is silver staining. Clear? And over time this disease can become multifocal and involve body and fundus too. Earlier it starts with the antrum, then it may involve body and fundus also. Okay, it may lead to involvement of body or fundus, and that will cause loss of parietal and chief cell, and that will lead to atrophic disease, and that will decrease acid secretion because parietal cells and chief cells are damaged. And this will lead to decreased risk of GERD, because if acid secretion is suppressed, then risk of GERD will be suppressed also. So that will lead to decreased risk of Barrett esophagus, okay, or esophageal carcinoma. So this is very important conceptual point, that H. pylori gastritis, this H. pylori gastritis is reducing the risk of your GERD, Barrett esophagus, and esophageal carcinoma. And how it is reducing the risk, I have explained you. Okay. Now, there will be intestinal metaplasia, and that will increase the risk of gastric adenocarcinoma. But H. pylori gastritis will lead to increased risk of gastric adenocarcinoma, because it is increasing intestinal metaplasia, and intestinal metaplasia will lead to increased risk of gastric adenocarcinoma. Getting a point? Okay. Now coming to the diagnostic test for H. pylori. So the first, the gold standard test we have discussed. Gold standard test we have discussed, that is the demonstration of H. pylori by Giemsa staining or like that. Second, you can go for the serology. The third, you can go for urea breath test. Urea breath test, or you may go for biopsy. So these are the diagnostic factors for the H. pylori. Now coming to the autoimmune gastritis. So here you will get lymphocyte and plasma cells, and it affects body of stomach mainly. Okay, and antibody are against the parietal cells and intrinsic factors. So because the antibody are forming against intrinsic factor also, so that will cause vitamin B12 deficiency, and because it is damaging parietal cells, so it will decrease acid, and that decreased acid will cause G cell hyperplasia, and that will lead to increased risk of carcinoma. So all the points are conceptual, you understand. Parietal cell damage, so acid will decrease. If acid will decrease, then G cell hyperplasia will be occur, and these are G cell basically are neuroendocrine cell, and if neuroendocrine cell hyperplasia is occurring, that will increase the risk of carcinoma. Okay. Now inflammatory cells are seen more in deeper layers as compared to H. pylori gastritis in case of autoimmune gastritis. Okay. So this is about your inflammatory conditions. Okay, that is chronic gastritis or like this. Now along with it, I will also discuss here peptic ulcer, and in next video I will focus on this malabsorption disease, which are also very important for your viva and examination. So let's first discuss about the peptic ulcer, because peptic ulcer and this chronic gastritis are related to each other. Now coming to the defensive forces, which usually means in normal condition, what are the defensive forces present in your stomach? So it is categorized in three forms, that is defensive forces. First, pre-epithelial defensive forces. What are the pre-epithelial defensive forces? So two, the first one is your mucus, okay, and the second one is your bicarbonate. So these are the two pre-epithelial defensive factor. You can also write this in your chronic gastritis topic. Okay. Now the second is your epithelial defensive factor. So it includes basically regenerative capacity of the epithelium, and the second one is your prostaglandin secretion. So prostaglandin and regenerative capacity of epithelium coming under this. The third one is your subepithelial, and it basically includes mucosal, blood flow, okay, and leukocytes. So these are the protective factors, defensive factors we have categorized into pre-epithelial, epithelial, and subepithelial. And normal damaging forces are, in normal condition, what are the damaging forces? So gastric acidity and your pepsin. But due to these protective factors, they are not able to show their effect. Okay, now coming to damaging forces which cause a direct mucosal damage. So that is H. pylori infection, the first and most important. Then NSAID. Then the third one is your cigarette smoking. Okay, cigarette smoking also leads to peptic ulcer. Then same alcohol. So these are the damaging forces which directly causes mucosal damage, and basically this will impair defensive forces, and they all will cause ischemia, or they will cause shock, and that will lead to ulceration. Okay, so these are the basic classification of the defensive forces and the risk factor and the basic pathology behind the peptic ulcer. Now one more important point, that is morphology. What you will get in morphology of peptic ulcer, that is very frequently asked in your examination. Okay, very frequently asked in your examination. So I am going to discuss that. Very important. 1 minute. So let's focus on that part. Okay, so what you will get in morphology. So first important point, that is what are the sites of peptic ulcer. That is very important. So most common site is your duodenum, not your stomach. Remember this, most common site is duodenum, and in duodenum most commonly involve first part of duodenum. Secondly, you will get stomach. Sorry for the sound of my writing is also coming in this video, sorry for that. Okay, in stomach lesser curvature is most commonly involved. Then gastroesophageal junction will be involved. Then your anastomotic sites are involved. Okay, it develops at the anastomotic site in patients who have undergone a distal gastric surgery or resection in that. Then multiple ulcers are also seen in Zollinger-Ellison syndrome. Usually ulcers are single, but in JES you will get multiple ulcers. Now coming to the size, so lesion less than 0.3 centimeter in diameter are also seen. Okay, they are shallow, and those larger than 0.6 centimeter, they are deeper ulcer. And shape is round to oval, and the most important point, that is punched out defect is there. Punched out defect. Okay, punched out. This is the very important. This is the most important gross finding. That is round to oval and punched out defect. That is very important. Now coming to the margin. So margin is usually in level with surrounding mucosa. Okay, margin is in level with surrounding mucosa. Base is smooth and clean, and you can differentiate it from gastric cancer, because in gastric cancer hipped up margins are seen. Remember this is very frequently asked viva question. Hipped up margin are seen in gastric carcinoma, where it is absent in peptic ulcer. And you can also look for the diagram of peptic ulcer, which is given in Robbins, diagram 1711. Okay, so this is the basic gross morphology which I have discussed. Now coming to the microscopy, what you will find in peptic ulcer. So basically 4 layers you will get. The first layer is your necrotic zone, the second layer is exudative zone, and the third layer you will get granulation tissue zone, and the fourth layer is your zone of cicatrization. So first layer is your necrotic zone, then superficial exudative zone, then your granulation tissue zone, and then final is your zone of cicatrization. Okay, and complications of the gastric ulcers are, the first is your bleeding, then perforation may occur and may lead to malignant transformation also. Okay, so these are the important points about this. Now one homework for you all who are watching this video, you have to just differentiate between gastric ulcer and duodenal ulcer. I will discuss this point in my next video, but you have to differentiate, because it is a very important short note question for your semester examination. So if I will forget about it, please go and read this, gastric ulcer and duodenal ulcer. So thank you for watching the video. Please subscribe if you are not subscribed my video earlier. Please subscribe our channel and support us.